call upon Dr. NAMRATA Sharma to speak on IOCT guided DMEK. So this is our last talk, and we have, we have exactly 12 minutes time to go. So I think time is perfect.
Thank you, sir. I would be speaking to you about intraoperative OCT guided DMEK. Not that you need it. Only thing is your surgery becomes a little more refined, and it helps you understand the dynamics much better. So there are no financial or proprietary interests. And OCT is a non-invasive diagnostic technique which renders an in vivo cross-sectional view of the optical tissue. And we have microscope integrated OCT, and I am going to be talking about that. The advantages are that it gives you real-time images, dynamic visualization, and continuous and simultaneous acquisition and display of OCT images possible. But of course, the flip side is that it is expensive and it may not be available at all centers. So you do the donor dissection and the host dissection. When you do the donor dissection, it actually does not, it's actually not required because the Descemet's membrane is already stained with the trypan blue dye. But sometimes when adhesions are present, then it helps to identify that on the intraop OCT microscope. And after the Descemet's membrane is detached from all the sides, trifronation mark is given, and then subsequently this pure Descemet's roll is then elevated as shown. This is a punch, a 3 millimeter punch which is being made, and once this is made, on this the Descemet's membrane roll is again slid back, and again the part of the peripheral part is dried a little bit so that to stabilize the graft. Now, following this, an S-shaped stamp is being made and looks like a desmetocele on the intraop OCT microscope, and this cover of this is then placed back in position, and then subsequently the graft is then dissected almost 8 or 8.5 millimeter, and then this is placed in the Petri dish which has the media. Now, this is a case of fixed dystrophy for which the cataract surgery has been done, and now the Descemet's membrane scoring is being done. And again, if there are adhesions or remnants which are present, these can be seen on the intraop OCT microscope, and these can be adhered. And this is the Descemet's membrane roll which is then injected in the injector, and this is centralized, and now you have to get this biceps curl upwards configuration. So this is absolutely upside down, and after putting in fluid, you get that biceps curl configuration. The graft is then unrolled, and following this, the air bubble is instilled, and the graft gets stuck to the back of the cornea. This is how, this was the case that I showed you, and looks quite clear. You can't even make out where the graft is following a DMEK surgery. Now, it is of special use in hazy medias, because in hazy medias, which is a reality in our part of the world, you can't see where the Descemet's membrane remnants are, and you can't even see the S-shaped stamp. So all the adhesions which are present or remnants which are present are addressed using the intraop OCT microscope, and this is again a Descemet's membrane roll which is then instilled, which is like a tight scroll, and then as you tap, it gets again into the configuration of a biceps curl upwards, and then again, you know, this is a correct side of the graft, the endothelial side down. Now, this is the same case that I had shown the video of. Then in hazy cornea such as this, orientation at times may become problem, and in this case, the graft is very much there, but its orientation is not correct. And like I said, the correct orientation is a biceps curl upwards. So when you get that, looking at the intraop OCT microscope, even though the cornea is hazy, one can still tap the graft to come into the correct position. And once you have that biceps curl upwards, uh, air bubble can be instilled. And even if when the S is not visible, you can put a blob of viscoelastic here. So as soon as you put a blob of viscoelastic, it gets magnified a little, and then you can see where the graft is. Now sometimes there can be folds in the graft. Like in this case, the unrolling of the graft was done to get it into the correct configuration. S is also staring at you, which is absolutely fine. But then there are folds which are present here at the edge of the graft. So to undo the folds, you have to actually put the fluid between the graft and the overlying cornea, and then from the other side put the air bubbles. So this has now got completely unrolled out, and then you can see that there is no longer the fold which is present. Then in eye syndrome, again, it helps because there may be adhesions which may be present underneath. So again, the Descemet's membrane stripping is done, and the graft is placed in position. And when the correct side is up, one can instill the air bubble. I think it is very useful for eye syndromes because it has a dual purpose of looking at the adhesions as well as also unrolling the graft. Now, this is a case of failed DMEK for failed DSEK following penetrating keratoplasty. So just at as the graft is being removed, the DSEK graft, there are adhesions which are present between the underlying iris and the DSEK lenticule. So very gently the iris adhesions are tweezed off, and again when you're loading the graft, you can actually load it in the manner in which it should be loaded, with the biceps curl upwards, and then in the same manner one can eject it out, again taking into consideration that the endothelial side has to be down with the correct S looking at you. Now this I called a case of auto DMEK because the surgeon did the surgery, the whole Descemet's membrane came out, and then he pushed back the Descemet's membrane inside and didn't know which side up. So he referred the case to us. The case was immediately taken up, and it was a challenge to understand which side is up and where is the Descemet's membrane. So I call it auto DMEK because this is the patient's own completely detached Descemet's membrane after 2 hours of surgery, which was referred to us. And then again you can look at the intraop OCT microscope and see which is the correct side which is there, and then get the correct side to stick on the correct side. And then alternatively, even if you don't have an intraop OCT microscope, you can stain it with a trypan blue dye also. But I think if you have an intraop OCT microscope, then it just helps because that guides you a little better than the trypan blue dye. Then there can be problems with DMEK, all of which can be sorted out by the use of IOCT. Now, this is just to show that there can be problems in the sense that once you put the graft, you get the graft to go inside, it may be possible that it ejects out. Now, in this case, it has ejected out. So, it is ejected out mainly because your fluid has gone much before than the graft. So, adequate dock is very important because if you have an inadequate dock, there is a gap wherein the fluid can push the graft outside. So, if you completely dock when you are actually putting in the graft, then this will not happen. So, your fluid has to actually be above your docked area and not with your injector, and the graft has to be loaded in the way that you load it with the correct configuration only. So to conclude, intraop OCT is a useful tool in the armamentarium of endothelial keratoplasty, in fact for all keratoplasty surgeon, because it helps to refine the DMEK surgery, and of course modifications and quantifications are required in the current system for accuracy. So thank you very much for your kind attention.